All right, thank you for joining us today for today's event on the medical review on the destruction of benign skin lesions. And it's on the Targeted Probe and Educate that's starting on this. My name is Mary Sue Gardner, and I'm a registered nurse on the Provider Outreach and Education team. And I'm going to be your facilitator for today's event. I'm also joined by other members of Provider Outreach and Education, as well as Medical Review, who are going to be helping with the chat section as well as the Q&A for today's call. Today's event will focus on the newly initiated Targeted Probe and Educate review that we started last month in our Jurisdiction 5, so that's Nebraska, Iowa, Kansas, Missouri, for our Part B providers. A few housekeeping items before we get started. As I mentioned briefly on the last slide, on our website, wpsgha.com, we have a training center link at the top of the page. In our training center, you're going to find all things education, such as the training materials like the slide deck, upcoming educational events, and even encore presentations that we talked about. So again, those encore presentations will remain on our website for around 60 to 90 days, but they're always available on our YouTube section or YouTube page until that information is either changed or updated. If you have questions during today's event, you can place those questions into the chat and make sure you send that to all panelists. Finally, if you have any feedback about your experience today, there will be opportunity during and after the event to take the survey. Jennifer's going to place a link in the chat right now, and she'll also place a link in the chat later at the end of this presentation. So if you find you have to leave the event early, please go ahead and take our survey, when you're leaving the event. If you're listening to this event as an encore, we also encourage you to take the encore survey. Now, the encore survey you should be able to access it from the top left of your screen. There should be a little eye with a circle around it, but it's also available in the description as well as a link at the end. All right. I will be referring to CPT codes in this presentation, so I have to give you a CPT code notice and disclaimer. So that's just in there if you choose to read it. And as always, we have a disclaimer for our event. And basically our disclaimer says, what I'm telling you today is as good as it is today. But know that Medicare laws, rules, and regulations often change. And it's your responsibility as a provider to make sure you're following the most current laws, rules, and regulations that are in place on the day of service you are providing services to a Medicare beneficiary. So Medicare themselves have the final determination in coverage ruling. All right. So let's move on and get started. On your screen right now are some acronyms that I may refer to in this presentation. If I happen to spew out an acronym that you don't know what that means, just either refer back to this acronyms page if it's listed here, or put it in the chat and one of my associates will define that for you. Medicare is like acronym soup. So there's an acronym for just about everything in Medicare. So again, if I say something and you don't understand it, just go ahead and refer back to this page. All right, my objective for today is that you, our provider community, learn about our newly initiated Targeted Probe and Educate, or TPE, that we're doing on the destruction of benign skin lesions that are specific to destruction procedures on benign or pre-malignant lesions of the let's just say skin system. We're going to accomplish this today by going through some of that local coverage determination information and refer to the local coverage determination. And we're going to have a discussion about documentation requirements, and we're going to go through some information that'll help you prepare for mitigation of risk to, you know, having a claim that doesn't meet medical necessity. So we're going to start with the coverage and the local coverage determination. The local coverage determination and coverage guidance for these services is what we are going to use for reviews to make sure that you, our provider community, are meeting the coverage criteria and guidance for these services. Now, this policy addresses the Medicare coverage for the removal of benign skin lesions, and, you know, such as seborrheic keratosis, sebaceous cysts, skin tags, etc. Benign skin lesions are common in our elderly community and are frequently removed at the patient's request to improve appearance. So the removal of certain benign skin lesions that do not pose a threat or health or function, those are considered cosmetic and as such are not covered by the Medicare program. So we want to make sure that your documentation, your billing, everything is as it needs to be to support medical necessity, and that it doesn't appear that things are cosmetic in nature. So if you go through our LCD, there are medical indications for coverage listed. There may be instances in which the removal of non-malignant skin lesions is medically appropriate. Medicare will therefore consider their removal as medically necessary and not cosmetic if one of the following conditions are present and they're clearly documented in your medical record. So these are the things that we're going to go through and look for. We're going to look and see if one of these are present. So if there's a lesion that has characteristics of bleeding or itching or pain or even changes in physical appearance, like recent enlargement or increase in number. Is there evidence of inflammation? Does the lesion obstruct an orifice? Does it restrict vision? Is there some sort of clinical uncertainty of the likelihood of the diagnosis? Like, is it perhaps a malignant lesion? So if there's prior biopsies that have been done that suggest that this lesion is in fact malignant, that's something we would also need to know. Anatomical regions, was there recent trauma, and therefore do we have the documentation of that trauma, of that area to support that? And then we move into things like wart removals, which will be covered under the guidelines, but they have to have one of those indications that we listed before, as well as wart destruction under the following circumstances. So listed here are things like the periocular warts associated with chronic recurrent conjunctivitis, warts that show evidence of spread from one body area to another, et cetera. So those indications are listed here as well. So when you go out to our local coverage determination and local coverage article, these are the things that you're going to be looking at and making sure your documentation supports. Now, I am going to, move that, maybe, if my computer doesn't lock up. Okay, I am going to pull up the local coverage determination, and we're going to go through that through the CMS site, because all local coverage determinations are housed on cms.gov. And the easiest way to get that, well, I shouldn't say the easiest. There's several ways. You can do a search by MCD database, but I just go Medicare coverage database. That's MCD database. Let's say you don't remember the name or number of the local coverage determination. You can just simply type in here, skin lesions, and you want to make sure you are picking a WPS state. So I'm just going to choose Iowa. So here you can see LCD 35498, removal of benign skin lesions. You have to accept that. And then you'll be at our local coverage determination. I do encourage whenever you go to the Medicare coverage database and you go to a LCD, the first thing you should do is really click on this contractor drop-down and make sure you are using an LCD that is for us as your Medicare contractor. So it should say Wisconsin Physicians Service Insurance Company here, and this one does. So again, if you go on through, here are those indications of medical necessity that we just talked about. All right. And then while I'm on this, and we're going to jump in and out of it several times, while I'm on this, I'm going to scroll all the way to the bottom, or almost to the bottom, and here is the link for the billing and coding article. Now, we received several questions in advance about the billing of these services. I'm going to cover a little bit about the billing, but enough to talk about how we utilize what is on your bill in our review determinations. So I do encourage you to go to our local coverage article and review the CPT codes, review the ICD-9 diagnosis codes, review the modifiers, all those things that need to be in place to make your claim reasonable and necessary for billing. And then again, we're going to talk mostly about how it's supported in the coverage criteria and how you prove that in your documentation. So I'll minimize that. And again, we'll jump back and forth as needed. All right. So as we move on, payment for the excision of benign skin lesions of the skin include payment for simple repairs. So separate payment may be made for medically necessary layered closures of adjacent tissues and transfers and flaps and grafts. So know that that does exist too. And that is also listed in our local coverage determination. So just as there is indications of medical necessity, there are also limitations when Medicare will not pay. So Medicare will not pay a separate E&M service on the same day as one of these dermatologic services unless a documented significant and separately identifiable medical necessity service is rendered. So the service really has to be clearly documented in that patient's medical record. That modifier 25 should also be appended to that. And upon review, we're going to look for things that make sure that you're not double dipping. So what I mean by that is that those two things have to be able to stand alone in your documentation. So all the documentation of that separate E&M code needs to stand by itself. The medical decision-making for that service, everything needs to be met for that E&M service. And it has to be completely separate from the documentation that you use to support your dermatological procedure. So you can't use some of your medical decision-making from the E&M visit in your supporting your procedure code as well. So that's why it needs to, again, be separate and distinct. And I like to always just make sure that providers are well aware of that because we have started these reviews and we have already seen some instances where we can't say the two services, it's not evident that the two services are separate and distinct. So usually what happens is there's going to be denial of services in one way, shape, or form. So know that those limitations do exist. And separate E&M by the operating physician during the global period, unless the surgery is unless the service is unrelated. So remember, these procedures have a global period of time too, that you can't bill for additional services or additional E&Ms. But if there's something that's completely separate and distinct, then that needs to be billed the correct way and it needs to be modified the correct way. Of course, the limitation that we've already talked about is cosmetic purposes. So Medicare is not going to pay for these benign skin lesions to be removed when it's strictly for cosmetic purposes. Our local coverage article actually contains some information that we'll talk about after a little while about what you do if your patient just wants that claim reported to Medicare, even though it is not medically necessary to do. So again, we'll talk about that a little later. And then remember, the type of removal is at the discretion of the treating physician, and the appropriateness of the technique used will not be a factor in deciding if a lesion merits removal. However, a benign lesion excision must have medical record documentation as to why that excision or removal needs to be done, other than for cosmetic purposes. So what was the surgical procedure of choice is something that needs to also be expressed in your documentation. All right, and then each benign lesion that's excised should be reported separately in your documentation. So if you are doing multiple lesions and this CPT code is up to 14 lesions, you need to be describing each of those lesions separately. That's part of the documentation that needs to be kept. All right. Now let's move on and really briefly touch on non-medically necessary lesions. If your beneficiary wishes to have one or more of these benign asymptomatic lesions removed for cosmetic purposes, the beneficiary becomes liable for those services rendered. Your physician has the responsibility of notifying that patient in advance that Medicare will not cover that cosmetic dermatological surgery and that the beneficiary is going to be liable for the cost of that service. It is strongly advised that the beneficiary, by his or her signature, takes responsibility of payment. So charges should be clearly stated to the beneficiary as well. So you should do that in advance of the service. All right, let's move on and talk about documentation and documentation guidance. Remember, your documentation must match the codes that you submit to Medicare for payment. Your documentation is that link between the delivery of and the payment for those services provided. So things that we're going to expect to support in your documentation and billing include proof of medical necessity. So the medical records maintained by the physician must clearly support the medical necessity of removal of that lesion. And that must clearly indicate that it is medically necessary, that we've met those indications, and that you're going to bill Medicare for the service. We're going to look towards the physician's history and physical and progress notes to support this. The relevant history and physical findings that conform to the criteria stated in the indications and limitations of medical necessity that we spoke about earlier are what we're going to be looking for. So on this slide, if you have the slide deck, I've hyperlinked you back to those indications information in the slide deck. So I'm just going to quickly link right back to there. And again, we need to know that it's not cosmetic. We need one or more of the following conditions present. And lesions have characteristics, again, of bleeding, itching, pain, changes in physical appearance, etc. Prior biopsies that indicate malignancy, etc., etc. So I'm going to go back to the page we were on. All right. Oops. And we'll just advance through this way. It's not going back the way I need it. All right. So remember, you must clearly document those indications to support the coverage of the medical necessity of those services. So without those medical indications, we can't assume that it is not cosmetic. You know, we have to make a review determination on how your documentation stands when it is submitted to us. Remember, another piece of documentation to include is the operative notes that show exactly what was done during the procedure. Your operative notes for a surgical procedure that's performed in like the office location may be contained in your patient's medical record in their office notes, again, for the date of service, or they could be a separate report that's maintained somewhere in the patient's chart. Either way, somehow we need to see those operative notes. The operative note for the procedure must be of significant detail to support that surgical procedure that you build. So the surgical technique should be described, what surgical technique was used, describe that. Surgical procedures should include the lesion size, the location, and the number of lesions. Is there layered closures that are being done? So if that is done, that should be included. Lengths of the lesions as well, recorded usually in centimeters. If there's multiple closures, then there's going to be multiple lengths and multiple, perhaps, anatomical sites that are listed as well. So make sure that you're choosing, or make sure you are documenting appropriately, and make sure your notes include indications of all lesions, size, location, etc., that are being removed. As we move on with more documentation guidance, remember there are covered diagnoses in our local coverage article that you must make sure you are meeting as well. Remember that local coverage article gives you the cover procedure codes as well as suggested modifiers and diagnoses that support medical necessity. I'm going to just quick jump back and pull up that local coverage article again as well. So if you find the local coverage determination, remember you can scroll all the way to the bottom and link to the local coverage article. Same holds true with the local coverage article, where you can link right back to the local coverage determination. But again, I'm scrolling up a little slow. Avert your eyes if that makes you motion sick. But we get up here and we see the list of billing CPT codes for the removals. We're, in our review, focusing on the 17110. And then again, if modifiers are needed, what is allowable, as well as a plethora of ICD-10 diagnoses codes that help support. All right, other documentation, pathology interpretation. The decision to submit specimen for pathology interpretation will be dependent on your surgeon and if they want that. If they do send something to pathology, when you have those pathology reports, they should be kept in your patient's overall chart. And if we request medical review, then you should send that pathology as well. Again, patient complaints about the lesion. So has the patient said anything about any bleeding or itching, changes in size, any of those indications that we talked about before? Lost my brain for half a second. All documentation should be dated and signed. So make sure that your electronic medical record, if you're using EMRs, also we can see who was part of what in your documentation. So your physician's signature needs to be appended to those operative reports, et cetera. The physician's signature should be appended to their progress notes, et cetera. There's some EHRs that print funny, so they don't sometimes print with a list of signatures on just a separate sheet, and we don't know what signature goes with what service. So it's something you may just want to, take an eye on or take note of, and print one of your smaller charts and make sure you see that dates and signatures append appropriately to your documentation. And then finally, an ABN. If you administered one to the patient, then you should include it in your documentation. Keep in mind, you should only be issuing an ABN in the event that you have reason to believe that Medicare may not cover the service on this day for this patient, but it's generally payable and coverable. If it's cosmetic, it's excluded. Medicare doesn't pay cosmetic, so an ABN really isn't necessary in that manner. You can give one as a nicety, but it isn't necessary because it's something that's excluded and Medicare never pays for cosmetic procedures. So let's move on and talk about the review process. So again, starting last month, we started a review on CPT Code 17110, so the destruction of benign skin lesions other than skin tags or vascular lesions, up to 14 lesions in one encounter. This started because our data analysis for our J5B jurisdiction of work identified that these procedure codes represented a significant risk in the total dollars at risk, which were actually greater than the 95th percentile when compared to other procedure codes within that jurisdiction. So in an effort to examine why this procedure code represents such a risk to the Medicare Trust Fund in this jurisdiction, we have to investigate this. And we do that by doing claim reviews to ensure that what is being billed is being done properly and in accordance with Medicare standards, and you're following the local coverage determination for doing that. So our medical review staff actually uses the LCD that we talked about, so the L35498. And local coverage article, which is A57482, to help make those decisions. You don't have to write those down because they are on our resources page and they are linked in our resources page later in the presentation. So now I want to take some time to walk you through all these things that we've already discussed, but in a manner in which a review nurse may look at your documentation. So the first thing we're going to look at is verify that you have a covered diagnosis, and the covered diagnosis is appropriate for billing the CPT 17110. so again, listed here. And this is the only CPT under this targeted probe and educate that we are looking at this time. So this is what's driving the review. I know we made reference to the LCD and all the other covered procedure codes, et cetera, but for this medical review, this is the focus of the review. So again, we're going to look, is there covered diagnosis for the billing of the 17110? Next, we're going to go to those covered indications that we discussed several times. And again, you can use this hyperlink, go back to those covered indications, or go find them in the LCD. And we're going to look that the lesion has one or more of those characteristics, like bleeding, itching, pain, changes in appearance, if there's evidence of inflammation, if it obstructs an orifice, or if it restricts vision, you know, any of those characteristics of malignancy, et cetera, those things that are listed under the indications that we talked about. If it is a wart removal, we will again look for those covered indications just like we spoke about, as well as one of the indications listed on this slide for the wart removal. So the periocular warts associated with chronic recurrent conjunctivitis, warts that show evidence of spread from one body area to the other, cervical dysplasia, pregnancy, molluscum, contagium, et cetera. So all of those things listed here, we're going to look and see if one of these is also in your documentation, if it happens to be a wart removal or multiple wart removals. As part of the review, we're going to look to see that you've submitted all those documentation requirements that we've talked about. So things that we need in order to review your documentation appropriately for this service. And that includes that procedure report, any kind of operative notes, lesions, that those are documented. And again, remember, this CPT code is up to 14 lesions. We're going to look for those characteristics listed in the indications. That's all part of the documentation requirements. And then again, for wart removal, those indications as well as meeting one of these characteristics here. So those are all the things in your documentation that you for sure need to submit. If you have other pieces of documentation that you believe help support the medical necessity of the service that you provided, that supports the 17110, and it's not listed as one of these documentation requirements, by all means, if you are requested for targeted probe and educate review, make sure you are submitting that as part of your documentation. It's better to submit more things that help support what you are doing than less things and risk a denial. All right, so how can you reduce the risk of a review denial? First, by checking your documentation. So make sure you are supporting everything that we have talked about up to this point in your documentation. Make sure it's accurate. Make sure it reflects what you have billed to Medicare. On this slide, there's some questions to review in your facility. So does your documentation include a covered diagnosis? Those diagnoses are supported in our local coverage determination. The proof of coverage indications, the proof of coverage indications for wart removal. Does your documentation include your operative report? Is there proof of how many lesions were removed? And finally, proof that what is billed is matched in your documentation. And then again, switching over, check your bill. This is, again, another way to help mitigate risk. Use the CPT code that best describes the procedure you are doing. The provider should use the appropriate CPT code and diagnosis code, and those should, should match together, should be CPT and diagnosis codes that go together. So for example, if a provider bills a benign skin lesion CPT code, it is not correct to use a malignant diagnosis code. If the beneficiary wishes to have one or more benign asymptomatic lesions removed that pose no threat to the health or function for cosmetic purposes, then really the physician, again, needs to explain that in advance, that Medicare is not going to cover because it is considered cosmetic. Need to let the beneficiary know that they're going to be liable for the cost of those services. And they should let the beneficiary know what the cost of those services should be so they can make an informed consent about that. A claim for cosmetic services does not need to be submitted to the Medicare contractor unless that patient requests that that claim be submitted on his or her behalf. So the local coverage article, again, has information in it if the patient requests that that claim for a cosmetic service be submitted on their behalf. Sometimes they want it just for a denial, so maybe a different insurance that they have if they have another secondary payer may consider the bill. So we know that that happens, and so sometimes they want it submitted on their behalf, or they just want to make sure that you're not lying to them, and they ask you to submit the bill and just make sure we're not going to pay. So again, use that LCA, use the instructions in that LCA to help make that determination. But again, to mitigate risk, you need to look at the questions about your billing. So does your bill reflect what's documented? Does it contain the correct code combinations, the correct code that describes the procedure you are performing? Does it contain the correct number of units? If there's an E&M service provided on that day, have we checked our claims to make sure if they are subject to global surgery rules before we bill them? Does it contain only one unit of service if you're billing the CPT code 17110? Because again, that is up to 14 lesions. And then finally, does it contain the appropriate, again, CPT code billing combination? So that was a lot. Again, remember our focus today is really to make you aware that we have started a targeted probe and educate review in our J5 Part B jurisdiction, and that's specific to the 17110. If you were not chosen for targeted probe and educate, that's great, but know that when we start reviews, that we can expand reviews if we start seeing more and more issues with more and more providers billing a service that we might be potentially finding to be billed in error. So just because you're off the hook now doesn't mean you're not going to be on the hook later. So that's why we want to bring you this information in advance so you know exactly what to have in your documentation, exactly how to throw it on your bill, and you're prepared for a possible review should we come knocking. Medicare, we want to look at your documentation. So we learned a lot today. We learned about that new review, that new targeted review on the destruction of benign skin lesions. We've reviewed how to find that local coverage determination, local coverage articles. We discussed some documentation requirements, as well as how to prepare and mitigate risk of having findings in your own provider office. these are links to some of these resources that may be beneficial to you. So this will link you right to the local coverage determination and the local coverage article. There is an article on our website about the targeted probe and education on the destruction of skin growth that may be of interest to you, and just additional information on the targeted probe and educate reviews. So we are, I know, at the end of our call end time, and I know there's a few questions in the chat, but what I'm going to do is ask Jennifer if there's anything that she may have answered that she just wants to, that one of our other associates just wants to make sure we tell everyone. And if not, I will be writing something up about these questions that came in, and I'll just send it in an email to everyone that participated. So Jennifer, was there anything that we specifically want to highlight that you might have answered that we want to say to everyone?
I want to just do one of them, just to make a confirmation because this won't take too long. We did get a comment or a question wanting to confirm that each lesion for code 17110 1 through 14 needs to have medical necessity. And I believe you touched on that, but if you just want to confirm that.
Yes, that is in fact true. So each lesion does need to meet the medical necessity requirements. So you do need a description, and you do need to touch on those covered indications for each lesion, because some of those in there could be cosmetic, and we don't want to pay for things that are cosmetic. All right. All right, so that is going to take us to the end of our formal presentation. I just want to finish up with just a few items of interest for everyone. And again, I will send out the rest of those questions and answers just via email to everyone that participated today. You should get in your mailbox in the next couple of minutes an email that basically says, thanks for participating. This email also is your certificate of achievement, so it has contact hours in it if you happen to need those for continuing education. So it will also have a link to the survey if you don't want to take it in one of the other manners that we have discussed. If you leave and you find you have follow-up questions in the next couple of days and that you didn't think of or that we weren't able to get to, go ahead and email those to us at this email address listed. It's wps.gha.education@wpsic.com. If you have the slide deck, you can go ahead and click on that, and it will formulate the email that says question on this service, you know, and generate the start of the email for you. Send those to us within the next 7 days. But if it's something claim specific, if it's something that needs to be looked up because of your billing or whatever, those really have to go to customer service because we don't have access to the billing systems. We can't look up a claim, and I would hate for you to send an email that contained any kind of PHI or PII. So we don't want to put either you or us into that situation. Take a moment, a couple moments, to take our survey. I want to know, I value your opinion, so I want to know what you liked, what you didn't like. But most of all, our survey gives you the opportunity to say what other types of education you need in the future. And we usually take those educational suggestions and make them into an event or an article or get that information out to you in some other way, shape, or form. So please, you know, take our survey, take it to completion. I know it's a little bit long, but it is valuable to us and it's valuable to CMS because that's how they rate us as a contractor, is through your opinion and your survey. And finally, I want to thank you for attending today. So on behalf of myself and Jennifer, as well as Medical Review, we want to thank you for your participation in today's event. Now, this concludes our webinar, and you may now disconnect.